Hello everyone and welcome to Forensic Extract, and today's topic is about general management in case of poisoning. So how to manage in case of any poisoning. So we'll divide this management into different steps. First is the step of stabilization. Step of stabilization. Then the second step, that is removal of unabsorbed unabsorbed poison. So this is the second step, that is removal of unabsorbed poison. Then the step number 3, that is removal of absorbed poison. This is step number 3. Then the step number 4, that is the use of specific antidotes. Use of specific antidotes. And the final step is the step of symptomatic treatment. So in this step of stabilization, we'll go for A, B, C, and D. A stands for airway maintenance, B for breathing, C for circulation, and D for CNS depression. So first, these steps, ABCD steps, are used by Scandinavian physicians. So these are the physicians who used these steps in case of barbiturate poisoning. Barbiturate poisoning, in which these steps were used first. So these are known as Scandinavian procedure also. So this is the step of stabilization. Then after the step of stabilization, we will go for removal of unabsorbed poison. So how can we remove unabsorbed poison? By simply washing with soap and water from skin, or by simple irrigation of eyes, or by giving emetics, or by doing gastric lavage, or by cathartics, or whole bowel irrigation. So these are the methods which are used for removing unabsorbed poison. Emetics are usually not recommended. Emetics are usually not recommended, but only one emetic, that is Epicac, that can be used in 15 ml dose in pediatric population and 30 ml dose in adult population. So this is the one emetic that is recommended, is the Epicac. Then we will go for gastric lavage. This is the important method that is known as gastric irrigation, or gastric pumping. Gastric irrigation or gastric pumping. So the gastric lavage is done in different poisoning by using a tube, usually made up of rubber or PVC. These are named tubes. That one such tube is a Wells tube, and second is lavaquator. Lavaquator. That this word lavaquator came from lavage, and evacuator. So lavaquator. So this tube is the best tube for gastric lavage. Then the second tube is the Wells tube. It's having two ends. One is a funnel shape end, This is the funnel shape end with a mouth gag there. It can be made up of plastic or the wooden. Then a suction bulb is there. Then the opposite end with 2 3 openings. So this is the tube is having two markings, one at 50 centimeters and another at 100 centimeters. So this is the gastric lavage tube, and the gastric lavage tube can be inserted in the oral cavity and esophagus and the stomach. So this length and these markings will indicate the site of tube after insertion, whether the tube has entered in the stomach or not. So we will check by these markings. Now the important topic or important question asked in various PG entrance as well as in UG examination, that is the contraindications, that gastric lavage is contraindicated in certain conditions. So first of all, the absolute absolute contraindications. So absolute contraindication is the corrosive poisoning. So gastric lavage is absolutely contraindicated in any corrosive poisoning because there is already thinning of mucosa in case of corrosive poisoning, and this tube after insertion in the stomach, this tube will cause perforation. So that's why this gastric lavage is contraindicated in case of corrosive poisoning. Then we are having relative contraindications. So what are relative contraindications are? If the person is comatose. Obviously, gastric lavage cannot be done if the patient is comatose or patient has ingested any volatile substance like kerosene or hydrocarbons, because more chances of aspiration in case of volatile substance poisoning, or sometimes esophageal varices may be there in case of a patient of chronic liver disease. Esophageal varices may be there. There are also relative contraindications. In case of pregnancy, or if the person is having convulsions, then also gastric lavage is contraindicated. So these are relative contraindications, and the corrosive poisoning is the absolute contraindication of gastric lavage. Now the important complications. So among the complications, the most common complication of gastric lavage is the aspiration, aspiration, pneumonitis, aspiration pneumonitis. Other complications can be like electrolyte imbalance, electrolyte imbalance, can be perforation, can be sudden arrhythmia. So these are the complications of gastric lavage. So the how to remove unabsorbed poisons. First is the emetics, second is the gastric lavage. Now third procedure that can be done by giving cathartics. Catharsis can be done whether with activated charcoal or without activated charcoal by using sorbitol or magnesium citrate. Magnesium citrate, 6% magnesium citrate can be used. But if catharsis is not useful in certain poisoning, we can go for whole bowel irrigation. Whole bowel irrigation, in which the whole bowel is irrigated by giving polyethylene glycol, and the whole bowel is irrigated in 4 to 6 hours. So these are the methods like cathartics, emetics, and gastric lavage for removing unabsorbed poison. Now, how to remove absorbed poison? The poison is already absorbed in the blood. So how to remove that? This is one of the important step. How to remove that poison? So one important step is the by increasing renal excretion. Renal excretion. So if we will increase the renal excretion of that poison, that will also helpful in removing absorbed poison. So before proceeding, we have to understand certain important concepts that the condition of the poison, whether the poison is ionized or not ionized, that is very important. Because if the ionized, poison is in ionized condition, it will not reabsorb. Or if the poison is non-ionized condition, then it will reabsorb from PCT or other ducts of nephrons. So a graph between pH and the percentage of ionization, and we'll take the example of an acidic drug like aspirin. So what happens that the percentage of ionization of aspirin will increase as the pH is increasing, and the pH at which the aspirin is 50% ionized, it is known as pK. So depending on the nature of the poison, whether it is acidic or base, we will change the condition in nephrons. Like if the drug is acidic, we'll try to alkalinize urine, or if the drug is basic or alkaline, then we'll give acidic substance for removal of that drug. So that drug will be more and more ionized and it will not reabsorb, and increasing, thus we will increase the excretion of that drug from kidney. So this is the basic concept in the urine alkalinization. So earlier it was a procedure that was used, that is known as forced alkaline or acidic diuresis, but it was the procedure which was very harmful because it causes fluid overload. So we will simply alkalinize or add some acidic substance for increasing the excretion of any drug. Now the other procedure is the dialysis. We can go for hemodialysis or peritoneal dialysis. So in case of hemodialysis, some drugs or some poisoning in which the hemodialysis is recommended, that can be remembered simply by a mnemonic, that is blast. So B stands for barbiturates or boric acid. L stands for lithium. A for alcohol. S stands for salicylate or strychnine.
and T stands for thiocyanate, and theophylline. So these are few examples of drugs in which the hemodialysis is very useful. But hemodialysis is not recommended in certain poisonings, like that can be remembered by A, B, C, and D. A stands for anticholinergic and antidepressant, antidepressant and antihistaminic, antihistaminics. B stands for benzodiazepines, C for chloroquine, and D for digitalis. Digitalis. So this list is long, but I have taken few examples in which the hemodialysis is very useful. So that can be remembered by ABCD, and hemodialysis only recommended in blast. So these are barbiturates and boric acid, L for lithium, A for alcohol, and S for salicylates and strychnine, and T for theophylline and thiocyanate. So we will go for hemodialysis in these drugs, and we will not go for hemodialysis in these ABCD. Now the use of specific antidotes. So as we all know, the definition of antidote is that it is a therapeutic substance that counteracts that counteracts the effect of any poison. So it is a therapeutic substance that counteracts the effect of any poison or xenobiotic, that is known as antidote. Now there are different types of antidote. That antidotes can be physical antidote or the mechanical antidote. They can be chemical antidote. They can be pharmacological antidotes. So the list is long, and sometimes chelating agents are also very useful in various poisoning. So the one of the most important topic for PG as well as the UG examination is the physical and mechanical antidote. They can be divided into adsorbents, demulcents, and diluents. So adsorbents are the mechanical antidote. The example is activated charcoal. So they adsorb the poisonous substance on their surface, thus causes excretion of that poison substance by decreasing its absorption. So activated charcoal is made by destructive distillation. It means that burning any substance without air is responsible for formation of activated charcoal. Burning any substance which contains carbon, like bone, like carbonaceous material or anything. So burning that substance without air causes increase in surface area. So the recommended dose is 1 gram per kg body weight. So this is the dose of activated charcoal. Sometimes We can use multi-dose activated charcoal, because what happens that in stomach the pH is low, so activated charcoal binds with a drug A. That drug is acidic, but as the drug reaches in the intestine, the pH changes and the activated charcoal dissociates uh, with that drug. So we have to give second dose or third dose of activated charcoal to maintain the required dose or the concentration of activated charcoal in the intestine. So that's why there is the concept of multi-dose activated charcoal that is given in multiple doses. Now the second physical or the mechanical antidote is the demulcents. So these are the antidotes which forms a layer on the gastric mucosa. So prevent further absorption of any poisonous substance. These are demulcents, and diluents are the physical or mechanical antidotes which dilutes the poisonous substance, thus decreasing its absorption. So, so far we have studied about the stabilization, then the how to remove unabsorbed poison, then how to remove absorbed poison, then specific antidotes. So stabilization may we have discussed about A, B, C and D. How to remove unabsorbed poison from skin by simple washing, and from eyes by irrigation. We can use emetics, we can use gastric lavage, and we can go for catharsis or whole bowel irrigation. Then how to remove absorbed poison by simply going for dialysis or by urine, alkalinization or acidification. And use of specific antidotes. We have discussed about physical and or mechanical antidotes. Now something about chelating agents. Chelating agents. So these are the agents which are very useful in treating various poisonings because they form a chelate ring. So this is the characteristic feature of any chelating agents, that they form chelate ring, and the meaning of chela is the claw-like. So chela, literally meaning of chela is claw. So they forms a stable ring and it is non-toxic. Non-toxic. So the first chelating agent is the British anti-levisite or dimercaprol. Dimercaprol. It is a yellow, viscous, oily liquid. Oily liquid that is having a sulfurous odor. So its odor is similar to sulfur. Sulfurous odor. The dimercaprol or British anti-levisite is having two sulfhydryl groups, two SH groups, two binds with any uh, poisonous substance. It can be given deep intramuscularly because the solution is oily, so we cannot go for IV injection. So it should be given deep intramuscular, and it comes in 3 ml ampule that contains British anti-levisite, benzyl benzoate that is a stabilizing solution, and the oil of arachis or peanut oil. So these are the three constituents of the ampule of British anti-levisite. So British anti-levisite is the antidote in case of the poisoning of mercury, arsenic and lead. So this is the antidote in case of poisoning by mercury, arsenic and lead. There are some contraindications of British anti-levisite. It is not recommended in case of cadmium poisoning. It is not recommended in case of iron poisoning. because it increases the nephrotoxicity of cadmium by increasing the reabsorption of cadmium from kidneys, and it is not recommended in case of iron poisoning, and sometimes it is not recommended in case of hepatic dysfunction as well, hepatic dysfunctions, and G6PD deficiency also. So this is about British anti-levisite, and as we have discussed that British anti-levisite is the lipid solution that can be given only deep intramuscularly. So we are having oral alternates of British anti-levisite. These are DMSA and DMPS that can be used orally because these two drugs are available in capsule forms. These are alternatives of British anti-levisite. Then the second antidote is the calcium disodium EDTA, calcium disodium EDTA. So this is one of the important chelating agent. It causes pain when we will give in intramuscular route. It causes pain, so we have to go for IV route, and that too in infusion form. Infusion. So the 0.5% solution is infused in 24 hours, and the calcium disodium EDTA is preferred over disodium EDTA, because if we will give disodium EDTA, then it will cause severe hypokalemia by binding with calcium. So calcium disodium EDTA is preferred over disodium EDTA, and it is the chelating agent that is recommended in lead poisoning. Now the next chelating agent, that is D-penicillamine. D-penicillamine. D-penicillamine, or otherwise known as cuprimine or Depen. So it is the chelating agent which is recommended in the poisoning by mercury, lead, and copper. So in case of mercury, lead, and copper poisoning, we'll go for D-penicillamine. Sometimes in case of Indian childhood cirrhosis, the agent of choice is the D-penicillamine also, and the dose of D-penicillamine is 30 milligram per kg body weight. Now the other chelating agent is the desferrexamine. Desferrexamine. This is the agent which is formed by a actinobacter named as Streptomyces pilosus. Streptomyces pilosus is a actinobacter which forms desferrexamine for consumption of iron. So it is a chelating agent for used in iron overload, and it comes in two forms, in 500 milligram and 2 gram, while in lyophilized form. So this is desferrexamine. This is a chelating agent of choice in case of iron poisoning. So this is all about the antidotes, and previously we have discussed about activated charcoal. So activated charcoal is usually recommended in various poisoning, but in various entrance examination, it is a frequently asked question that what are the exceptions of activated charcoal in which the activated charcoal is not recommended. So that can be easily remembered by the mnemonic CS line. C stands for corrosives, S for salicylates, L for lithium, I stands for iron, M stands for methanol, and E stands for ethyl alcohol and ethylene glycol. So these are few exceptions in which activated charcoal is not recommended at all. So this is all about the general management or general guidelines of any case of poisoning, how to manage a case of poisoning. And the last step is the symptomatic treatment that can be done by giving, like the patient is having convulsion, then we can go for anti-convulsants, and patient is having some allergic reaction, then we can go for anti-allergic drugs, or so we will treat the patient according to the symptoms. So to recapitulate, we have 5 steps. First is step of stabilization, that is A, B, C, and D. Then how to remove unabsorbed poison by emetics, gastric lavage, and catharsis and whole bowel irrigation. Then the step number 3, how to remove absorbed substance, that is by increasing renal excretion, or by dialysis, whether hemodialysis or peritoneal dialysis. Then the step number 4 is specific antidotes, that can be physical or mechanical, pharmacological, or the chelating agents. Then the symptomatic treatment. So this is all about the basic management of any poisoning. So thank you guys, and please do subscribe Forensic Extract, and gradually we'll cover the other topics of toxicology. So thank you guys.